A very good evening to one and all. I heartily welcome all the members of the API ICP Karnataka Old Medical Academy and other members of various organizations who have joined virtually from all over the country to attend this program on World Obesity Day. On this occasion, I welcome Dr. P.A. Shankar, Professor Emeritus RGHS and KB University Gulbarga, Dr. Muruganathan, past Governor ACP India Chapter and past Dean and President API, who is joining shortly. I also welcome our own committee members, our patron API, Dr. Maya, Dr. Murali Mohan, Chairman API, Dr. Vishwanath, Secretary, Dr. Ravi Kirti, and Dr. L. Srinivas Murthy, Central API members. I welcome our today's chief guest, Dr. R.K. Singhal, Dean ICP from Delhi, a great academician who readily accepted our invitation to be part of this program from Delhi, a dynamic leader of API with great visionary, taking API to great heights both nationally and internationally. I welcome our today's speaker, Dr. A.S. Jargar, a renowned endocrinologist both nationally and internationally from Srinagar, a close associate of ours who accepted our invitation in a short period notice of time. I also welcome our other speaker, Padma Bhushan awardee, Dr. D. Nageshwar Reddy, renowned gastroenterologist of the world, a great academician, researcher, scientist who never said no to our invitation in spite of his busy schedule, that speaks his dedication to academics and passion for sharing knowledge globally. A teacher par excellence, received innumerable awards and hundreds of publications to his credit. I welcome our chief moderator, Dr. Prasanna Kumar, endocrinologist from Bangalore, a great teacher, researcher with many publications and received many awards. I welcome our today's panelist, Dr. Professor Anup Misra, who will be joining shortly, endocrinologist from Delhi, the chairman of Fortis Center of Excellence for Diabetes, Metabolic Diseases and Endocrinology. I received many awards, including Padma Shri and P.C. Roy awardee, delivered many orations, written chapters, published many articles, a great scientist, a teacher par excellence. I also welcome our other panelist, Dr. Pramila Kalra, Professor and HOD Endocrinology from Ramaya Medical College, Bangalore, a great teacher with many publications to her credit. Let us not waste time by reading their CV profile, which runs in pages. Let us learn and hear from them. As I can see, many have joined virtually from many states of the country, making a national event, which COVID-19 pandemic has taught a new normal life to learn. Lastly, I welcome one and all. Now we have a formal virtual inauguration.
शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः
We are virtually honoring all them for their contributions and for joining for today's program. We are playing a small promotional video on World Obesity Day.
Obesity is a mix of many factors. To find real solutions, we need to talk about obesity and
the environment shape our choices. So let's talk about food system, public places, the workspace, free from stigma and discrimination. We need access to information that's evidence-based, free from diet gurus or influencers, and we need a health system that is prepared for the obesity epidemic.
Obesity amongst youth is increasing rapidly. This is due to a food system that fails us and inundates us with ultra-processed foods, exacerbating inequalities that affect our healthcare, education and environment. But now we demand change. We are pushing for solutions for youth, by youth.
Let's talk about obesity and health, NCDs, diabetes, and cardiovascular disease. Let's talk about solving the problem together.
Now I request Dr. P.S. Shankar to address and for his introductory remarks.
Thank you. Dr. Singhal, Dr. Muruganathan, Dr. Zarga, Dr. Nageshwar Reddy, Dr. Prasanna Kumar, Dr. Mishra, Dr. Maya, Dr. Murali Mohan, Vishwanath, Sangram, Ravi Kirti, Srinivas Murthy, and Dr. Alsetti, colleagues and friends. We have assembled here to celebrate the World Obesity Day in order to utilize the practical solutions to help people achieve and maintain a healthy weight. It also guides them to undertake proper treatment and reverse the obesity crisis. In the recent decades, the number of obese people, that too among the youngsters, has increased. We see them in airports, railway stations, bus stands, and marketplaces. Many children and adolescents in every country are found to put on weight. We are all aware that obesity is a major risk factor for many non-communicable diseases such as type 2 diabetes, hypertension, ischemic heart disease, stroke, and even cancer. World Obesity Day was founded by the World Obesity Federation with the support of the World Health Organization and the collaboration of the Lancet Commission. It was first observed in 2015. Then it became an annual campaign with the goal of stimulating and supporting practical actions that will help people achieve and maintain a healthy weight and reverse the global obesity crisis. Every year on World Obesity Day, there is a different theme to highlight an issue related to obesity. These themes are intended to raise awareness and encourage people to take action to prevent and treat obesity. The World Obesity Day used to be celebrated on October 11, and since 2020, the date has been shifted to 4th March. The theme for the year, let us talk about obesity, and this calls for people around the world to come together to address a global crisis. Obesity is a global health issue and has taken epidemic proportions. The worrying aspect of this medical issue is that it is affecting populations worldwide. The World Obesity Federation indicates that if current trend continue, by next year, 2.7 billion adults worldwide will be overweight. Obesity is the number one cause and poses as risk factor for many other diseases and is linked to high mortality rates. We have to put our effort and concentrate on children to develop healthy food habits and to undertake proper exercise. There is need to give guidance on the prevention and treatment of the overweight and obesity. Obesity affects 2 billion people worldwide. The complexity of the disease, the challenge of developing lasting solutions, and the burden of stigma has necessitated to work together to fight this challenge. It requires a social responsibility that includes radical solutions in terms of prevention, treatment, and attention to a healthy lifestyle. Obesity rates has tripled since 1975 and have increased almost 5 times in children and adolescents, affecting people of all ages from all social groups in both developed and developing countries. The root cause of obesity are a complex mixture of dietary, lifestyle, genetic, psychological, socio-cultural, economic, and environmental factors. It is time we break the cycle of shame and blame and reevaluate our approach for addressing this complex global public health problem. You know, obesity is initially enviable, later laughable, and ultimately pitiable. The weight of the world is changing. Overweight and obesity, defined as abnormal or excessive fat accumulation, kill more people than underweight. And the fundamental cause of obesity is an energy imbalance between the calories consumed and calories expended. It is necessary to prevent weight gain by adopting healthy lifestyles. The highest obesity rates are found in small island nations like Nauru, Cook Islands, Marshall Islands, Palau Islands, which have got 55 to 61% of the population obese. Five most obese developed countries: Mexico, US, China, Greece, and Canada, where it varies from 25 to 30%. And on the other side of the spectrum, countries such as Japan and Vietnam have lowest rate of obesity in the world. Japan has only 3.3% and Vietnam 2.1% obesity rates. Naturally, a question will be asked why it is so low in those countries. These countries have a culture that values a healthy lifestyle and diet. It may be a contributing factor to the low rates of obesity. There is a lower consumption of processed food. Most of the world's population is living in the countries where overweight and obesity is killing more people than underweight. People are realizing that what they eat is important. They can't put junk food in their body and expect to be healthy. We must remember the words of Robert Hurrick. He said, "A healthy outside starts from inside." World Obesity Day promotes the resources for the practical solutions that can help people to treat obesity early and maintain a healthy weight and lifestyle. Often it is said, avoid anything processed. Exercise such as a daily walk of 30 minutes can make all the difference. Rates of obesity are rising particularly quickly among children and in the lower income countries. Louis Brown, president of the World Obesity Federation, has said it is a clear warning and the policymakers need to act now to prevent the situation worsening. Obesity is a problem that nearly every nation in the world is facing. We celebrated Wildlife Day yesterday. We should know that tiger kills its prey but does not devour it completely. It eats only that much proportion that is needed. And we have never seen a tiger being obese, and it should be a lesson to us. This year's theme emphasizes to encourage people to start conversations that address obesity from cross-cutting perspectives. And the idea is to look at the health, youth, and the world as a whole in order to find ways to combat obesity together. I congratulate the organizer, Dr. Sangram, and I am happy to join in the inauguration of this program, and I wish the deliberations all success. Thank you.
Thank you, sir, for your introductory remarks. Now I request Dr. Muruganathan, sir, to say a few words. Dr. Muruganathan.
Yeah, thank you, Dr. Sangram. I am in Chennai, so my video is not working, but still, first of all, I congratulate Sangram for organizing and observing all the days. You know, when I was the president of API, I told our branches and members, you should observe the particular day. So Sangram is regularly, routinely observing all the days. Only thing he did not observe World Wildlife Day as Sangar was saying. Maybe that also he should follow. But Sangar was relating Wildlife Day and obesity. Even tiger doesn't have hypertension, sir, because they eat only raw meat, not the oil food, fried things. So tigers don't have high blood pressure. They don't have obesity. And one important message to all patients, you should empower the patient in obesity control, and you should not observe obesity day only one day. You should observe obesity day all the days. Then only obesity can be controlled. Not only all the days, all the meetings, morning breakfast, lunch, and dinner. So it's better to have empower the patient with the weighing machine. So before he eats, he should weigh his weight so that he will have awareness about his own weight. And empowering the patient is the best way to reduce obesity. Once again, thank you for the opportunity, Sangram. All the best.
Thank you, sir, for your kind words. Since Dr. R.K. Singhal is held up in an emergency, he will be joining anytime. We will have his remarks. on the middle of the talk. So now we move on to the scientific session. I request Dr. Prasanna Kumar sir to take over the proceedings for further. As all the speakers have been introduced already, sir. Over to you, Dr. Prasanna.
Good evening, everybody. Thank you, Dr. Sangram Brother and Dr. Shankar, Dr. Muruganathan, Dr. Srinivas Murthy, Dr. Maya, and all the speakers here, Dr. Zargar and Dr. Nageshwar Reddy, and Dr. Anup Mishra will be joining us shortly, as well as Premla Kalra. And welcome to all the members who are joined here for this talk. And now the first talk will be by Dr. Abdul Hamid Zargar. He will be talking about epidemiology of diabetes. After that, Dr. Nageshwara will talk. Then we'll have a panel, both these speakers plus two more, as I said, Anup Mishra, as well as Dr. Premla Kalra will join. Over to Dr. Abdul Hamid Zargar to give his talk on obesity, the epidemiology. He has done excellent work in Kashmir Valley as well as in India, and lot of work for the last 4 decades, emerging epidemic of obesity. Over to Dr. Zargar.
Thank you so much, Dr. Sangram, for this invitation, and thank you, Prasanna Kumar, always for your affection. In the next 20 minutes, I'll be mostly focusing on our own country, but also in the context of what Professor Patil was talking about, what is happening globally. But these trends that are emerging, I personally believe that we have not been able to change much of lifestyle of mankind, or whatever I have seen in the last 40 years. Prasanna, just look at this slide. In 1960s, in the United States, and when they realized that coronary artery was a big issue, obesity was coming, dyslipidemia was coming, United States of America started the so-called cholesterol education program, and which later became ATP1, ATP2, ATP3, the lipid management. And that time people started talking about obesity. And particularly starting in the Western world, we were not there yet in 60s because we were still going through infections, communicable diseases were at the top. And they continue to be at the top for the next 3-4 decades. And just this 2 slides I put yesterday, tells us a lot about human nature. Just look at this slide. 4 decades after people started educating in the United States, public healthcare workers, that coronary artery disease is coming, dyslipidemia is coming, obesity is coming. And this is the state of obesity in 2000. The blue would mean 20% people are obese in those states. That brown would mean around 20 to 25%, and the dark brown would be more than 25%. And now just keep this in mind how it was. These are CDC data, how it was in 2000. And just look at it, how it is just half a decade later. In spite of almost half a century's education, every state has worsened. So it means, whatever efforts, even in that nation where we think people are educated, where we think access to information is huge, where most of the people have access to information, particularly healthcare, doesn't seem to have worked. Just doesn't seem to have worked. Just look at it. It's just amazing how everything is worsened in 6 years only, and it's getting worse by the thereafter. I personally believe that taking food, whatever you start taking in pre-pubertal period or in young days, has a huge addicting influence. And it's very difficult for many people to correct those habits. And, it's something like, people not able to get rid of smoking, people not getting rid of cocaine. And suddenly you realize that food is killing more people than cocaine globally. And this is what is the stats. And all of us know what impact it has on mortality, morbidity. I'll not get into that because that's so obvious. This is a paper that we published about 2.5 decades back. And we thought, Kashmir all being, more rural society, people would walk quite a bit. But we were amazed that obesity started coming up, 15%. And what I could not understand then, obesity was twice commoner in women than in men. And for quite some time, I was trying to find out reason and rationality for that. And many times we argued that, yes, probably most of the rural women are homebound, not going for the jobs. Is that the reason? But then when we really looked at most of the women, particularly in the rural area, they were physically more engaging than men. You see, they will prepare food in the morning and then go to the fields along with those men, then come in the middle of the day, get food for them. And so we did not know. And this another study that we did in a relatively youngish population, 20 and 40. I started realizing that it has already started happening from 20. First, I thought it was a middle-aged phenomenon occurring after 40th birthday. And we published a paper in 5 to 15 years kids after this. And things had started happening that people, were presuming that a thickish child is a healthy child. And as Professor Patil very aptly said, it looks beautiful in the younger days. It looks full of morbidity in the middle age, but then it makes you bedridden in your old time. And this is what had started happening. For last more than a decade, there has been a global group active in looking at what is happening to non-communicable diseases globally. All those people who have published in the last 30, 40 years in the field of non-communicable diseases were invited by the people who started this concept. Harvard University and Imperial College London. They took the precedence and they approached all authors who had published some data. And they created a group as non-communicable risk factor collaboration group. And we have been a part of this for more than a decade, and huge amount of data we had from different centers from India also, from our place also. And there's a paper, Prasanna, that came in Lancet. And data was up to 2014, but it got published in 2016, May. And looking at the trends of obesity, how obesity in India was in 1975 and how it moved beyond in 2014. Now look at this slide. This is the data in men, Indian men, globally all men, but we're focusing on India. If you look on your left side, Indian men stood at position number 19 in terms of absolute number of obese people. Whatever the number of, whatever the population of a nation, unrelated. Actually, if we quantify how many would qualify to be obese, in 1975, we were at position number 19. And that time also, we were a populous nation. We were second populous that time also, not today, only the number one. Smaller nations like France, Italy, Ukraine, Poland had more obese people than us, right? Now, if you look at 2014, progressively we have moved on to position number 4, Indian men. So it means the absolute number of obese people is progressively worsening in the country. And understandably, this trend would not stop short at 40 because we did nothing tangible to make it stop. It just is happening. And if this was the situation in men, this is in women. In 1975, we again were at position number 19. And look at it in 2014. We are at position number 3. Indian women are at position number 3. It means after China and United States, we have the third highest number of obese women in the country. So the problems thereof. Consequently, one of the first things that we as endocrinologists see is diabetes happening. Now look at it. When we did our post-graduation, India was postulated to have 11.9 million diabetics. In 2014, when this data was published, there was another paper that came in Lancet. It was 64.5 million. And now today, just a decade later, it is 101 million. And not only that, the age at the onset at which the type 2 diabetes would occur. Because of that massive increase in obesity, at least in a segment of population, maybe not in the whole country, but in a segment of population. You know, Prasanna, what I realize is when you have a population of 1.45 billion people, we are multiple nations into nations, you know, like 20 crore people who will be just like having data like United States. And then figures would be there. Progressively, the age at which the type 2 diabetes would occur is lessening. You see, in late 80s and 90s, diabetes would strike at 48. By the later part of the last decades, it would be 36. In-depth study showed that now it is 29.4 years on. That is the consequence that we're looking. It is not confined to diabetes alone. Just to look at this data again, published in Lancet in 2017. Pooled analysis of huge number of global data in children, adolescents, and young adults. Again, the trends are same, which I showed you, including a country. Then look at another paper, just looking at children, where that paper 5 to 15 years got attention. Again, you know, children and adolescents. So it means the whole situation is already happening at every age. Now, what is the consequence? Not necessarily every time. At that time, diabetes, many things started happening. Now, today, when we became endocrinologists, we would hardly see a polycystic ovarian syndrome in a week, 10 days. Now, today, polycystic ovarian syndrome is the commonest endocrinopathy in women globally and getting worse by the day. What used to occur in 22, 24, 25, now occurring in 12 years, 13 years, 15 years. And the consequences of that, which we never realize. Like, you know, you look at Hirschism, 1/3 of, you talk about taking care of laser, giving aldactone, anti-androgens, but they already have an advance in metabolic disease when they are 15, when they are 16. And the central adiposity is always not taken cognizance of. Then you look at infertility. The most treatable cause of female infertility would be today polycystic ovarian disease. But at what cost? At the cost to the family, healthcare cost to the couple, and the discomfort associated with that. Every third, fourth pregnancy now having gestation diabetes mellitus. It used to be a unique phenomenon when we started, and in our OPD at SKIMS in the first 2 decades, we would see once in a while in a week or 10 days GDM, and we would admit everyone. Now admit them today. If you have an open registry, you will be seeing every day a dozen from my own locality only. And that's what is happening because of this epidemiological. Now we're looking at young diabetics in our own clinic at SKIMS. But we found half of them have a telltale evidence of biological evidence of already polycystic ovarian syndrome and central adiposity. So more than one thing's happening, not one alone. This is a paper that came from this group in Nature in 2019. Now imagine now, at least in India still, obesity is an urban phenomena and semi-urban phenomena. Now that urban, semi-urban, and rural distinction is vanishing. Everything is everywhere. McDonald's is everywhere. KFC is everywhere. Kurkure is everywhere. And now when this epidemic reaches rural India, I can only feel aghast. What would be the biological and pathophysiological impact of that at the national? We aren't able to handle it today. Whatever consequences of obesity we are seeing today. Now imagine now, and I'm sure that this time we might have 1/4 of people who are on the thick side. Now imagine crossing the midline. And that is going to be a huge phenomenon. And this is INDAP exactly, which was published last year. Now forget about diabetes. Look at the central big bar, abdominal obesity. 351 million. And if you look at what data I showed you, this Lancet paper that was talking about 300 million. Now, in this phase of half a decade or so, another 50 million added to it. So 350 million, we already there. And wait another decade, it will be doubled up. And then the consequences of that we know. In earlier times, when we would talk about so-called quote-unquote non-alcoholic fatty liver disease, NASH, or now metabolic dysfunction-associated steatohepatitis, we would not take much cognizance of it. But now look at it today. Whether diabetes or no diabetes, the commonest cause of liver transplant today, and the cause is the same, metabolic dysfunction. So the problem is huge, particularly in our country. I mean, we are not a nation of, as Professor Shankar was talking about, Nero of 2 million and Marshall Islands of 1.5 million, but a nation of 1.5 billion people. And this is what exactly is happening in the government hospitals in the outdoors today. So yes, we have a huge problem, and I personally visualize this problem is going to stay because hardly anything is being done at the public level. I'll just make a half a second mention of my first slide. If the Americans haven't learned, we are less likely to learn. So prevention, probably education at a very early stage is the key. That takeoff point which starts at 5-10 years in the schools, we need to curtail it there. And we need to connect with the policy planners, healthcare planners, so that our nation can, I can simply say, our health services will be inundated. Our nation cannot afford it. Full stop. So the situation is dismal. We need to take care and we need to take it in hand. Thank you so much.
Thank you, Dr. Zargar, for an excellent talk. I want to remind people that somebody have already started putting their questions. After Zargar's talk, we have got Dr. Nageshwar Reddy's talk. Please put your questions in the chat box. And at the end of both the talks, after Dr. Nageshwar Reddy, we have got a panel discussion. Dr. Anup Mishra has just now joined us. He will be there in the panel discussion, along with Dr. Pramila Kalra. All your questions will be answered. So please put all your questions to Zargar or Dr. Nageshwar Reddy, as well as other panelists, so that we'll take up all the questions about obesity, whether obesity in diabetic or non-diabetic, because there are two distinct entities here. We have three endocrinologists talking about obesity in diabetes, and we have got a gastroenterologist talking about the obesity and what is the problem in gastroenterology, and we have cardiologist, physician. I think every branch of medicine has got obesity as such. And by Zargar's talk, it is very clear, probably India is in love with obesity. And you see how it is increasing 75 from poverty to plenty. Obesity is not a disease, but it's a mother of all diseases. Every specialist can talk about obesity, starting from pediatrics to geriatrics. Now we have got Dr. Nageshwar Reddy from Hyderabad. He'll be talking about the obesity and how that obesity is important and what is its effect. He'll be talking about endoscopic, bariatric, and metabolic therapy. Where are we and where we are going? Over to Dr. Nageshwar Reddy for his talk.
Thank you, Dr. Prasanna Kumar. I'd like to thank Sangram also for giving me an opportunity to be part of this very important and interesting symposium, which is dealing with obesity. And as Dr. Zargar just showed us all the data that India is in a big epidemic of this obesity and that this is going to be a serious problem in the future. I'm going to talk about, from the gastroenterologist point of view, what we are doing and what we can do in these cases. So I think this is very important. I think this is data that we have often seen and that I think also very well emphasized by Dr. Zargar, that 1/3 of our country is definitely overweight, rapidly going into obesity. And I think this is the first time in the history of mankind that there are more obese people than more hungry people. I think all the while we used to have malnutrition, starvation, and so on in Africa and India. But now, for the first time in the world, we have more obesity than starvation. So this is a very dangerous situation. Normally, the treatment would start with lifestyle changes, but there is a problem with this. The problem is, I think, diet and exercises can be effective only in a small percentage. In fact, it's shown that with diet and exercise on long term, we can actually decrease weights by 2 to 3%. That's all. Even if you decrease larger amount by severe starvation, you get it back immediately. So it's not very effective, and it's only for very small decreases in weight. Medication is a whole new chapter. I won't discuss on this, but there are a lot of new medications, the GLP-1 analogs coming in, which I think is a whole new chapter by itself. So most patients who were above 30 BMI or in grade A, 2 or 3 obesity used to get a sleeve gastrectomy or a surgical gastric bypass. So these were the two important things. Now, because most patients are worried about surgery for obesity and cannot do lifestyle modifications, there's a big unmet need with endoscopy. And what can be done endoscopically? There are two major ways of how obesity can be treated endoscopically. First is to fill the stomach with balloons. We have a special balloon which can be put endoscopically, intragastric balloon, which decreases the appetite. And of course, because the stomach cannot be filled completely, slowly the patient eats less. These balloons are removed after 6 months, and within 6 months, most patients will lose about 10% of their weight. But unfortunately, it's a temporary phenomena because they get back their weight again. The second method, more permanent method, is to do what surgeons have been doing, what we call endoscopic sleeve gastroplasty. That is endoscopically, which I'll show later, you can stitch up the stomach completely and make it into a small stomach. In addition to this gastric, there are also some small bowel interventions I'll show you a little later as we go along. So if we take all patients with obesity now, not only in our country but in the world, only less than 1% who really require will receive surgery. Rest of the people don't want to go for surgery. A small percentage are now going on medication. But over 90% of the people have an unmet need. They're not doing anything in this situation. So that's the reason why endoscopy is becoming very popular now. We have a huge demand. We have a department of metabolic and obesity with endoscopists is actually doing most of the cases. Because endoscopy is organ sparing, no long-term consequences, and it's minimally disruptive. So what we do endoscopically is that we use a technique where we can suture along the greater curve of the stomach. This is a simple outpatient procedure which takes about half an hour. The patient is not admitted, comes to us for endoscopy, we suture. And we also leave the fundus intact. So you see after this, how the stomach looks on barium X-ray after endoscopy suturing, a thin stomach with the fundus. And what we have found is that this is dramatically effective in decreasing satiety because most of the baroreceptors of the stomach are in the body of the stomach. So any distension of the stomach, immediately satiety reflexes get activated and you stop eating. Similarly, because the fundus is left intact, all the food accumulates in the fundus, distends the fundus, and causes again satiety reflex. For these two reasons, the food immediately produces satiety after taking half or less than half what you normally take. And therefore, because of decreased intake, you start to lose weight. So this was a very big study that was published recently in Lancet. This is called the MERIT study, which compared endoscopic sleeve gastroplasty for class 1 and class 2 obesity. Even those with 35 BMI were taken and randomized into endoscopic therapy and conventional treatment, that is diet, exercise, and so on. And this study very clearly showed that endoscopy is superior to conventional diet and exercise. So therefore, in those patients with say 30 to 35 BMI, you cannot get down the weight by standard lifestyle modifications and all. One would strongly advocate endoscopic sleeve gastroplasty. And what is increasingly happening is a combination now. People are taking endoscopic sleeve gastroplasty along with one of these newer compounds, semaglutide or even terzepeptide that has now come in, which has a combination of these drugs. So a combination. So first we do sleeve gastroplasty, and after 3 months start them on drug therapy. Many of these patients are losing up to 18% of their body weight with this combination. The only problem is after a year, when we stop these medicines, the patient tend to put on weight. So one has to be very, very strict about how patient's lifestyle is changed after that, so they don't put on weight again. So this is a combination. Now we'll switch gears and talk about something which is also very, very important. In addition to the obesity in form of central obesity, consequence of obesity like hypertension, cardiac problems, the bone problems, um, neurological problems, cancers and all, one of the most important aspects of obesity and the whole metabolic syndrome is the consequences that can occur to the liver. The healthy liver over a period of time in obese people goes fatty liver, gets inflamed NASH, and finally goes into cirrhosis. So this consequence, so-called non-alcoholic fatty liver disease, is itself becoming an epidemic in the world. 30% of Indians are having this, a huge number. And of course, you can see this combination of metabolic syndrome, central obesity that we see in our population, diabetes, type 2 diabetes mellitus, and NAFLD. This combination, along with hypertriglyceridemia, usually is called the metabolic syndrome. And this metabolic syndrome cannot be treated adequately nowadays with medications, and again, lifestyle change is very difficult, and surgery was the only option. The reason for this metabolic syndrome is predominantly insulin resistance, either because of obesity or there's even lean metabolic syndrome in people who have insulin resistance factor. And therefore, we come back to this. In these patients, if we can change the insulin resistance by any means, then we can, of course, treat these patients very effectively. And there are 2 or 3 very important endoscopic small bowel therapies that are available that the physician should know, which are very exciting, which may change the way we approach these patients. So let's talk about some of these changes. The first is regarding endoscopic balloons. When we put balloons, it has been shown very clearly that the liver fat after 6 months comes down dramatically. But unfortunately, this is not sustained. Similarly, liver inflammation comes down but not sustained. And there are several studies showing that putting in balloons in obesity not only decreases the weight, but also improves the metabolic parameters. But unfortunately, once the balloons are removed after 6 months, these patients will get back their weight and also will develop all the other features of metabolic syndrome. So a more permanent treatment is to do endoscopic stitching or endoscopic sleeve gastroplasty, where on the greater curve of the stomach, we can actually suture it up to make the stomach small and tubular. And this is a very interesting study. We showed that if you do this endoscopic sleeve gastroplasty, many of the metabolic factors improve. And this is showing that the liver fibrosis and steatosis comes down in addition to control of diabetes in these patients. So this is a very important finding. And this is a study from our institute which we published. We showed that after you do endoscopic sleeve gastroplasty after 6 months, all the liver enzymes get stabilized, stay stabilized for 12 months. So this is a very effective treatment for metabolic syndrome. So remember, obesity, diabetes, non-alcoholic fatty liver disease. The current best non-invasive therapy is endoscopic sleeve gastroplasty. Of course, now we are starting to use drugs also in these patients. Now let's come to another area, and this is in the small intestine. Very, very important, because we now know that there are many hormones which are produced by the small intestine, the duodenum, the second, third, fourth of the duodenum, and jejunum. These hormones are a combination of GLP-1, GLP-1 agonists, and GIP. So all these hormones together can give rise to a variety of hormones that you see here, can give rise to insulin resistance or modulate insulin resistance. Ghrelin is produced from the stomach, is responsible for hunger. This is also a separate hormone. In addition to all this, we have bile acid, which comes from into the small intestine, which can also regulate appetite and the consequences of this. So let me give you a new concept of glucose metabolism that's coming up. We all used to think that the glucose metabolism is controlled by pancreas because of secretion of insulin. Now the answer is no, this is not true. What is actually controlling the whole glucose metabolism and the metabolic problems in the body is this duodenum. In the duodenum, there are several hormones called incretins and anti-incretins, to easily remember this produced. And as the food passes through these hormones, area of duodenum, incretins and anti-incretins are produced in similar effect. This results in a euglycemia. Anti-incretins are now called the insulin-resistant factor or the diabetic intestinal peptide, the anti-incretins. But whatever it is, the ratio of these two will decide euglycemia. Because if you have too much incretins without anti-incretins, then you can result in dangerous hypoglycemia. So body adjusts both this. But what happens? Because of the refined food that we're eating now, the anti-incretins levels are increasing. And increased anti-incretins or insulin resistant factor results in increased insulin resistance, increased sugars, triglycerides, NASH, and truncal obesity. All these are consequences of an increased insulin resistant factor being secreted from the duodenum. And therefore, if we can modify the duodenal mucosa, we can modify all this. We now know that westernized diet, lifestyle changes, and of course, genetic background, which we Indians have, insulin resistant syndromes with metabolic disease like obesity, NASH, and of course, coronary artery strokes all develop. So now we have this fantastic ability to actually modify the insulin resistance, because we know that insulin resistance is produced by cells in the duodenal mucosa. What are these cells? These are enteroendocrine cells, or no, so-called neuroendocrine cells, which are producing this. They are only in the mucosa, not deeper. So if we destroy the mucosa of a person, you destroy all these cells and reset the metabolism again. And this is a very interesting concept that's coming, that the insulin resistant factor or the diabetic intestinal peptide, which is produced in high amounts in type 2 diabetes from the duodenum, can now be reset by modifying the duodenal mucosa and therefore reset the whole metabolic process. And this has been shown by experiments in humans and also in rats. If you feed rat westernized chow, it develops a large number of these neuroendocrine cells in the duodenal mucosa. If you ablate this duodenal mucosa, these rats will lose their insulin resistance and will respond dramatically to all forms of therapy. Actually, we knew this several years back when we found that patients who underwent surgery for obesity, Roux-en-Y bypass, immediately their insulin requirement dropped and they would go into hypoglycemia. They would not have lost weight, but the insulin resistance goes down. We were not sure why this happened till this very famous experiment came. This is a very interesting experiment where patients who had Roux-en-Y bypass were studied. They had hyperglycemia and insulin resistance. And you can see after Roux-en-Y bypass, the food bypasses the duodenum, goes directly into the jejunum. And these patients become normoglycemic. They lose their hyperglycemia. They lose their insulin resistance. But if we actually put a small feeding gastrostomy tube, and in addition to the oral food, they use small amount of food through the stomach, what happens is, as the food is passing through the duodenum, insulin resistant factor comes in, and these patients surprisingly become hyperglycemic even with small amount of food stimulating the duodenum. And therefore, we got no idea why this happens. Remove this tube, again normal feeding, they become normoglycemic. So obviously, there is some element of duodenal nutrient passage which influences insulin sensitivity by producing an insulin resistant factor, and that results in this metabolic syndrome. So how can you overcome this? If you put a tube, for example, where food can go inside, bypass this and go into the jejunum, you can actually cover all this insulin resistant factor mucosa and produce results. And this has been shown very clearly in this study. But more interestingly is this study called the duodenal mucosal resurfacing. We showed that if you go into the duodenum with endoscope and using hot water, we can actually ablate the duodenal mucosa, second, third, and fourth part. And once you ablate the mucosa, the new mucosa which grows does not contain the enteroendocrine cells, and there's dramatic improvement you find in the type 2 diabetes. And this is how it is done endoscopically. Fortunately, I had some experience with this at Brussels. Very easy procedure to do. And these patients will respond very well. And you can see the first study that was published in Gut a few years back, how their A1Cs dropped by 1.5%. The insulin resistance came down. The liver enzymes also came down, indicating that all metabolic processes improve after you do a single duodenal mucosal resurfacing. And this is an interesting study. We showed very clearly that in these patients, especially if they do not have gross, very high diabetes, DMR will definitely improve both the weight and the diabetes. So endoscopic duodenal mucosal resurfacing has a fantastic effect on the metabolic system of the stomach. decreases A1C, fasting glucose, decreases all the liver enzymes, and of course lipids, and decreases the overall body weight. So this is, I think, some studies to show the efficacy of this. But there are new types of duodenal mucosal resurfacing that are coming using laser, RFA, very simple techniques that any endoscopist can do. And this is, again, look at this very interesting procedure. This is a small tube that is passed along with the endoscope into the second part of the duodenum. In the second part of the duodenum, this tube becomes a small ring, and through the technique of electroporation, will destroy the whole duodenal mucosa without affecting the submucosa or without affecting the muscle. So very safe procedure. The duodenal mucosal cells get completely destroyed and new cells are formed which do not contain this neuroendocrine cells. And this is the first study published last year, where using this technique, we showed that you can actually destroy the duodenal mucosa completely. And when the duodenal mucosa is destroyed within 24 hours, it becomes necrotic, but within 3 weeks, new mucosa comes. But the most important difference is that the new mucosa does not contain the enteroendocrine cells like the old ones. And therefore, there's no insulin resistant factor being secreted. And these people get dramatic relief from the type 2 diabetes. In fact, 2 studies have been published on this. The first study from Abu Dhabi, you can see, these are patients who require 100% of them required insulin. And once we did this reset procedure, only 14% required insulin. 86% did not require insulin. Very, very dramatic results. Any drug also cannot do this. And so this is a selective way to ablate the duodenal cells, including the neuroendocrine cells. It is successful in 100% of the patients. It resulted in durable and clinically meaningful control of glycemia. And of course, future studies are being done. But more important, all the metabolic parameters, like liver fat, also is being controlled. And you can see the second study published from Amsterdam, exactly same results. 100% of the patients with insulin, A1C less than 7.5%, and only 14% required insulin at the end of the study, showing that, of course, you can very effectively decrease this insulin resistance factors. But again, very impressive, the liver fat. In the beginning of the study, 23 liver fat on average was 23% of the liver, but at the end of the study, liver fat is only 2.8%. Again, indicating that all metabolic parameters which are controlled by insulin resistance are reversed by this technique. And one of the most important thing also is central or truncal obesity, which is very common to Indians, is also showing dramatic response. So I think these techniques are now improving now. We have this very recent technique which we are starting in our institute soon. We're using a radio frequency ablation technique between 2 umbrellas. Using through the endoscope, we can ablate this duodenal mucosa up to its mucosa, and again produce a change in insulin resistance, effectively controlling type 2 diabetes, truncal obesity, and of course, non-alcoholic fatty liver disease. So these are very exciting times that are coming. As you can see that endoscopically now, both obesity using gastric balloon and endoscopic gastroplasty, and of course, the metabolic control of diabetes can be done very easily. Of course, all this requires a team effort. We have a fantastic team of endocrinologists, diabetologists, gastroenterologists, and basic scientists in our hospital working in this very interesting project. And we believe that as this is a very important problem in Indians and is going to be confined more and more to the Indian population, work in this area is very important. And again, I appreciate the chance that Dr. Sangram has given us, and Dr. Prasanna Kumar, and of course, Dr. Mishra, who are leaders in this field, for giving us the opportunity to be a part of this very important symposium. Thank you very much.
Thank you very much, Dr. Nageshwar Reddy. I am sure that the audience will benefit most. Lot of techniques that you have said that none of us are aware, at least I am not aware of it. And your talk is futuristic. I'm sure Asian Institute of Gastroenterology, one of the leading institutions in the country, maybe in the world. And I think a lot of our patients go there for this. And I think this type of research one day we'll see. Probably bariatric surgery will be outdated. Either minimal invasive surgery, what you are telling, that replacement of epithelial cells, it is very exciting. And maybe many of these insulin resistance or diabetic taking out, we are happy if you make us jobless in the next 10 years. that 50% of the load is taken out. Myself and Zargar want to be jobless at this age. So if a lot of them can really do it, either reduce insulin or reverse diabetes and all, that will be great. You raised a very important point that hungry index is equal. If you look at India, India is number 111 in hungry index. Out of 0 to 100, 100 is the worst, 0 is best. And out of 125 countries, it's 111. It has worsened from 107 to 111. What does it mean? We have a paradox. We have richest of the rich, maximum obesity, poorest of the poor. So equalizing that does not matter. We have to counter to both. So next exciting thing will be discussion. I'll come back to with all that. So I request the audience, put your questions. There are already questions coming out. Very interesting question to the panelists. I would like to start with Dr. Anup Mishra. Dr. Anup, you are there. Please.
Yeah, I'm very much there, but just one
there.
request.
Yes, tell me, Anup.
If you can relieve me in 15 minutes because I have another seminar waiting.
Okay. I'll finish all your questions. That's why I'm starting with you. You start
Okay,
at 7 o'clock, being a chief guest for
Keep
another.
him busy for the next 15 minutes.
Yes. So, Anup Mishra has published more than 350 papers. I think 300 papers are on metabolics. You are an expert on it. What I would like to ask is Dr. Shankar raised a point. What is obesity definition? Is it BMI or is it extra fat which has a high risk for serious diseases? How do you make out this whether it is fat or BMI, because you are an expert, and Indian data compared to Asians or European? Your take on this.
Thank you. I think this is a very important question, and this holds a lot of significance. Just to give you a background, that in 2009, we revised the definition of obesity for Asian Indian population, at least living in India, from the overweight from 25 to 23 and obesity from 30 to 25. Now, at that time, we did not know that we are starting almost a revolution from 2 points of view. One is that by changing the definition, there were 3 crore people within the ambit, immediately within the ambit of a physician to advise them diet, exercise, and so on. And the second thing was that this was adopted subsequently, although a little late, in 2015 by NICE in UK, and then subsequently by ADA. They said that 23 is the screening criteria for diabetes in the Asian population in the United States. Of course, it's fueled by many other studies also, but ours was a prime move. We saw it early. Now, at that time, we made a mistake that we only looked at BMI as a criteria. And looking back, I think that was a mistake, but it was a good beginner's step, I would say. There is no doubt, Dr. Prasanna, that body fat is the correct criteria, but body fat cannot be done all the time in the busy clinic in the advanced areas where only probably a weighing machine is available. So, the body fat is the correct criteria for diagnosing obesity. That is was known even at that time, and we put that in the paper itself. Then subsequently, last year, there was a movement from the Lancet Diabetes and Endocrinology, and they put the whole team of 55 people from all over the world, including Francisco Rabino, whose slide Dr. Nageshwar Reddy projected also. He is the leader of the group, and I was fortunate to be a part of this group, where it started looking at the different way of looking at the definition of obesity. So it's all good that if a person has a high BMI or high body fat, uh, he's labeled as obese. But is that really something which is going to create problem for him in the near future? Maybe in most of the people, but some people it does not. So there is obesity which is without much of consequences, and there is obesity with consequences. How to define that is not based on the BMI, because BMI is a faulty criteria for obesity. So even if we do body fat, we have to look further into it. So one way to look into it, whether this increased body fat or increased BMI is associated with any comorbid conditions. And the second thing is that whether it is associated with any physical problem. So let me give you an example. One person has a BMI of 27 and a body fat of 37%. Both indicate obesity. But this person is walking 5 kilometers a day, is watching his diet. His blood sugar is normal, his blood pressure is normal, his lipids are normal. He does, he does not manifest with any other comorbid diseases. He's in the so-called obesity without much of consequences. And the second person is a BMI of just 26, a body fat of 30%, not much obese in the terms of the criteria, but a person has diabetes, person has a knee problem, person has a lumbosacral spine problem, has shortness of breath on walking for half a kilometer. This clearly is something that we have to see. So both Lancet and at the same time we started working for Indian definition. We both have reached a stage where we have defined obesity in the simplest possible manner, in bifurcated into two: obesity without consequences and with obesity with consequences. Of course, I'm not in the position to divulge more details, but the Lancet paper is under review, and our paper on the Indian definition is also under review at this point of time. Within next 4 to 6 weeks, both will be published, first Lancet and then our paper, almost side by side. And that will herald a new definition of obesity for worldwide as far as for Indian population, and hopefully will benefit a lot of people.
Thank you very much for clarification. I hope next month all of us will be able to have access to it, which will make us probably more wise and then data-based. This is a question I think relevant to you. How do you diagnose visceral or subcutaneous fat clinically or any other simple method? This question is to Dr. Anup Mishra.
Yeah, I saw that question. I think it's very interesting question, and there is two ways to answer it. One, you are in the primary healthcare center or with the minimal of instruments, and the second thing is that you have everything available to you, and the cost is not a problem. So I will first answer the number one, where you are in the primary healthcare setup, and the visceral obesity will be best defined by the waist circumference. I would say waist circumference is better than waist hip ratio, because the waist hip ratio is the ratio. It changes with the, depending on how much is your hip, that will determine the ratio of the waist also. And suppose the hip muscles go down, the waist hip ratio indicates the visceral obesity, but it is not. So I would depend on waist circumference as one parameter, and waist height ratio is coming up also, which is another parameter. Some people use sagittal abdominal diameter also, but to measure that, a special instrument is needed, which is not available in most of the places. So an increase in the waist circumference is a fairly good surrogate marker for subcutaneous as well as visceral obesity, both together. Now, if you want to ask me how to measure a subcutaneous adiposity, then in the simplest possible manner, if you have a Harpinden's caliper, or there are many other types of calipers, we have a Harpinden's and Lange's caliper, with which we have skin fold measurement. And if you see most of our publications over last decade or so, we have measured subcutaneous fat in various parts of the body. And so there's a central subcutaneous fat and there's a peripheral subcutaneous fat. Peripheral is the biceps, triceps, and central is subscapular and suprailiac. And sometimes we do more, 7 to 8 places. This is very, very important because subcutaneous fat is more thicker as compared to the Western population. In Indian population, it is thicker. And there are multiple studies that, and we feel that the subcutaneous fat is perhaps more important than intra-abdominal visceral fat in Indian population as far as metabolism is concerned. So that is as far as the clinical assessment of subcutaneous fat is concerned. And there are equations to convert this subcutaneous fat, if you measure at 2 or 4 places, to a total body fat also. But those equations are based on the Western parameters. Now, when you have more, every other investigation available to you, then say subcutaneous fat is best measured by magnetic resonance imaging. And we have done a number of studies using MRI imaging. Uh, it is 2 ways you can do it. One way, if you have enough money, then you do slices every 5 centimeter in the abdomen and chest, and look at and by equation calculate the total volume of the subcutaneous fat, or at least truncal and abdominal. On the other hand, if you don't have that much of money, then you have a single slice at LT3, L4 level, and look at the subcutaneous fat and extrapolate that this is the subcutaneous fat, at least for abdominal region, which is not exactly true, but it still is something which we can do with a lesser amount of money. The second, similarly for intra-abdominal fat, both ways we can do it, multiple slices and a single slice. Now, some people think that this kind of fat is can be measured by the DEXA scan or bioimpedance. No, this is not the accurate way of measuring the subcutaneous intra-abdominal fat. Although overall regional fat can be measured, that say this is the total fat in the truncal region and this is the total fat in the. So these are MRI based methods are something which is mostly experimental and mostly research based. And I would say just doing a waist circumference, waist height ratio, and if you have caliper, measuring at least central skin fold, subcutaneous, scapular, and suprailiac will be good enough to give you good information.
Thank you very much. Before I let you go, I have a question which is very important. A lot of people ask, is there anything a good fat, bad fat? Fat anywhere is bad, fat anybody is good, or fat anywhere is bad. So is there something like a metabolically healthy obese, metabolically unhealthy obese? How do you distinguish? Is the management different?
Yeah, exactly. This is the what we have bifurcated in the current obesity definition. That if you have obesity and which is not causing much of a problem in the metabolism, then it's metabolic healthy, or in Indian definition, which we are going to unveil, is stage 1 diabetes, and metabolically unhealthy stage 2 diabetes, stage 2 obesity. Sorry, not diabetes, stage 2 obesity. So. So clearly that there is something like that, and that is the reality. But so there is another opinion that actually there is nothing like a metabolically healthy obesity at all, because somewhere or the other fat will create problem, whether it is a peripheral fat or central fat or subcutaneous fat, or it is the intra-abdominal fat. But some depots of fat are more problematic. And I feel that if you go away from these visceral, so-called intra-abdominal visceral fat and subcutaneous fat, and concentrate on liver fat, which Dr. Reddy was mentioning about, and pancreatic fat, those are the two most important depots of ectopic fat. The liver fat produces a whole lot of metabolic derangements, starting from the lipids to insulin resistance, and Ferritin A, which it secretes, hepatokine, actually goes to the pancreas. And if there is a fat in the pancreas, there is decrease in the beta cell function, and ferritin A further impairs the beta cell function. So both insulin resistance and impaired beta cell function occur just by deposition of hepatic and pancreatic fat. And there is a good evidence available that decrease in the hepatic and pancreatic fat, but whatever means that you have, whether you have diet or you have drugs or you have Dr. Nageshwar Reddy's wonderful techniques, any of those have, if they reduce the liver and pancreatic fat significantly, then there is a possibility of not only amelioration of diabetes, the stoppage of insulin and so on, but also reversal of diabetes.
Thank you very much, Dr. Anup Mishra. All of us appreciate your wisdom and knowledge, and I thank you. And then I will let you go because other three are already waiting. I don't know whether Dr. Premda Karpa is still muted or unmuted.
No, she's unmuted, sir. Dr. Reddy
Sir,
sir is
unmuted,
also,
unmuted.
he wants to go for a procedure. If you
Okay.
can relieve him in for the next, it will be better.
Okay. I will
Thank
ask
you.
Dr. Nageshwar Reddy.
Thank you,
very
sir.
much. So the
Thank
question is that all of us know that everybody today talks about fatty liver, fatty liver. Every ultrasound comes with fatty liver. And the question is, how do you manage this fatty liver? What is the relationship between obesity and fatty liver? What stage of this, the bariatric surgery, weight loss is still reversible, or something like cirrhosis where it's a point of no return? How do you manage this fatty liver, and how do you see that intervention should be done? Lifestyle, medications, or surgery? All three options you have.
I think this is, Dr. Prasanna Kumar, very important questions that are raised, which for a clinician, whether you're a gastroenterologist or a physician or endocrinologist, these are problems which you come across very often in clinical practice. You see nowadays in clinical practice, many patients come to us with a report of fatty liver disease. The first most important thing to remember is that just fatty liver disease report is not right. You will have to ask whether you're dealing with grade 1, grade 2, or grade 3. This grading of fatty liver disease in ultrasound is very easy now based upon certain criteria. That is the density in the liver versus what is happening to the kidney versus pancreas and all. You can actually compare and you can actually grade into 1, 2, and 3. Grade 1 fatty liver disease is present almost in even marginally obese or normal people also, and therefore we don't take much cognizance of this. So whenever an ultrasound report comes, ask your ultrasoundologist whether it's grade 1. If it's grade 1, you can ignore it, you don't have to worry. It's grade 2 and finally grade 3 which cause problem, because the sequence of events are grade 3 fatty liver disease will go into NASH, that is non-alcoholic steatohepatitis. The terminology is changing a little into metabolic steatohepatitis, but for general terminology is NASH, non-alcoholic steatohepatitis. Now, non-alcoholic steatohepatitis is when these people start having inflammatory cells in the liver. And the best way of looking at this is, at this point of time, you should get a fibroscan done. Fibroscan is just like ultrasound scan, but gives us the amount of fat in the liver plus amount of fibrosis, which is S and F, S1, S2, F1, F2, we say. So if the fibroscan shows that the patient has steatosis, which can be S1, S2, or S3, or fibrosis, which can be F1 or F2, especially F2 fibrosis means you're going into NASH. So always when you see an ultrasound scan report of stage 2, that is grade 2, then ask for a fibroscan. Fibroscan will tell us how much is the fibrosis and inflammation involved. Subsequently, over a period of time, 5 years sometimes, these patients will invariably go into chronic liver disease because of increasing fibrosis and cirrhosis, and even an incidence of hepatomas are increased. In fact, the largest amount of hepatomas in our country are now secondary to this NASH-related cirrhosis. So the consequences are very clear. There's one more interesting aspect, that some people will continue in their life to be in stage 1, will never go into stage 2 or 3. We don't know why. There's some genetic factors involved in this. The second interesting factor is that not only obese people, but some non-obese people will also have fatty liver disease. This is called lean NASH. So in India particularly, not in other countries, in India we have found because of genetic problems, 10% of people who have NASH or NAFLD will be lean, will not be fat. This is purely because of the insulin-resistant factor, as we discussed, that is being secreted, that causes this whole metabolic problem without obesity. Whereas 90% obesity is still very important. So we make a diagnosis. Now, ultimately, the method to completely confirm the diagnosis is to do a liver biopsy. The reason why liver biopsy is becoming important nowadays is because of medications that are coming up to treat. There are several new medications in hepatology, like obeticholic acid and so on, which we are using for this type of patients to reverse the liver fibrosis, and of course, the fatty liver also goes off. Now, weight reduction is a very important component of this, and this has been shown that if you reduce your weight by 5%, you can reduce the fat. If you reduce your weight by 10%, you can reduce your fat and you can also reverse fibrosis. So all of us in a patient with obese who has fatty liver disease, we'll ask them at least 5%, but if you do 10%, the fibrosis also is reversed. And then drugs, all these other drugs are coming in now, semaglutide and so on, also have an influence, but I think we should discuss this critically because there is some evidence now that drugs like semaglutide, although they're being in Western market, they're producing osteoporosis, they're producing sarcopenia, peculiar semaglutide phases is coming. So long-term, people believe that there may be risks involved in these drugs also.
Thank you very much. Before I let you go, there are very crucial things. All of us are clinicians, basically, whether physician, endocrinologist, and all. With so much of availability of fibroscan, many people come, sir, shall I do fibroscanning? The question is, who should be screened, whether every diabetic, if so, how frequently, or every obese, who should be screened in a physician's clinic for fibroscan? Whether it is done free or paying does not matter to me.
So this is a very important question. The problem with fibroscan is that there can be variability in the reports based upon the interpretation. So it is a variability, interpreter variability. And second, fibroscan varies, depends upon the patient's obesity. A very obese patient, no point in doing fibroscan because the waves don't go into the liver. So there's no point in doing. Patients having ascites, no point in doing fibroscan because the waves don't go inside. So this would be the fibroscan indicated mainly in patients who come with a report saying that there is grade 2 or grade 3 fatty liver disease. One. Number two, these patients are not very obese. Number three, these patients have not gone to chronic liver disease because we have seen many times patients already having cirrhosis, fibroscan is asked. No point because already fibrosis is there. So the indications are grade 2, grade 3 fatty liver disease, not very obese patients who have not gone into chronic liver disease. In these patients, fibroscan will give us enough information to guide treatment, to tell the patient lose so much weight, take these medications, and fibroscan should be repeated only after 6 months. I've seen again people repeating every month, there's no point, only after 6 months so that we can see some change.
What about diabetic patient?
So
diabetic patient, obese?
In diabetic patients, only if they have grade 2 or grade 3, NAFLD fibroscan should be done. In grade 1 or stage 1, fibroscan will not be of much help because anyhow we know steatohepatitis is there. It will just give a figure, 320, 360 and so on. That is of no value. So we should not do in these cases.
Lifestyle versus medication in fatty liver.
I think the fatty liver, as I said, if we can reduce your weight 5%, then, but the biggest problem I found, and I think this also many of us have had personal experience, that we can go up to 3% weight loss. So somebody who's say 80 kg can come down by 6-7 kg, but beyond that, beyond 5% is very difficult. Extreme starvation, very determination. Some people come down 10% also. But the problem is within 6 months to 1 year, they put back the weight. So lifestyle modifications are useful only up to 3% weight decrease. Beyond 3%, I think. So what I mean is that people who are becoming overweight in the early stages should immediately go to lifestyle changes because if they've gone beyond a certain point, then they can't decrease them.
Thank you very much. I will let you go. I know you're very busy. You are needed in the hospital. I thank you and appreciate on behalf of all the audience. I thank you.
Thank you, Dr. Prasanna Kumar. Thank you very much for involving me in this very important symposium. Thank you.
We look forward.
Thank you.
Now we move on to Dr. Zargar. There is a question. We speak so much about the prevention and all. Is primordial prevention possible? Because you said epidemiology. What have we done? What are you doing to see that for primordial prevention of obesity? What should government be doing?
I'll tell you, Prasanna, education is the key and persistent education. In fact, more than a decade back, I had suggested education and legislation that, every time you say, now you get 25% pizza more at the same cost. It comes on your television, it comes on my television, and kids are seeing it. Now, at the end of the day, as I was telling you, even in the United States, today, semaglutide and Manjaro, tirzepatide is selling so much. And but nobody is concentrating. I just show the first 2 slides. I'm just like, they cannot have more education than you have in the United States. The point is, you need to catch them young. I personally, honestly believe that obesity is a consequence of food addiction. Whatever food you get addicted to. We have seen it happening in my own medical school. When I did my graduation, post-graduation, I cannot recollect a single colleague who would qualify to be obese, or in my school. And today you see our grandchildren, you see our own children. I'm saying, like, genes could not have changed in just a couple of decades. Genes would not, they were there for you and for all of us. So I personally think, yes, education is the key, and you need to catch them early. As Swami Rajneesh used to say, family is good enough to spoil a kid in the first 7 years of life by putting the thoughts in their brains, and then they never change. That they think that is the ultimate truth, whether they die 70 or 170. In a similar fashion, what you end up in adulating at that age, in terms of culinary habits, it's going to stay. But more importantly, our own physical efforts in our country have dramatically changed. People, even for marketing, getting some food, getting some vegetable, auto nikalo, scooter nikalo. I'm so like, इनका बस चलता तो नेबरहुड मस्जिद मंदिर में भी नमाज के लिए भी स्कूटर पर ही चलते. So I think somebody needs to be at it. Somebody needs to be persistently at it. I had advocated to health ministry more than a decade and a half back. There should be a separate chapter on lifestyle, and there should be a ban on advertisement of the things that none of this, neither on alcohol nor on foods. That ban was implemented, and I don't know, even the today corporatization, it is not going to happen. Prasanna, in your own introductory remarks, you said an amazing thing. Our group published a paper in Lancet 3 days back. It came exactly on 29th of Feb on bipolarity, obesity and underweight. World is becoming obese. You know what is happening in Southeast Asia? We are, in fact, effective Southeast Asia with 1.5 billion people. You'll be stunned to know. I'll show you data next Sunday. Obesity is increasing, we showed you. Underweight is increasing, both. Only the normality is shrinking. Normality is shrinking. Obesity is increasing, underweight is increasing, normality is shrinking. I'm saying, where are we going? I personally believe, yes, in a nation like ours, primordial prevention is the only answer. We cannot afford. Once, we were creating a document for Vision 2035, and there was one, Mr. Salvamurthy, who was a scientific advisor to the then Prime Minister. And first vision document had been made by late Abul Kalam, our former president. And this guy had worked with Abul Kalam. He was his successor in DRDO. I said, ask this great man what sort of a population we are looking at by 2035. And next time I asked him that question, he said, yes, I had sought an appointment. I visited him. He said, we will not learn, plan for 3 billion people. Now, in that sort of a scenario, a procedure is excellent. But when you have a population of 1 million guys and you're able to do it on 10 people, when you have a population of 1 crore of people, you are doing on 1,000 people, what is the effective impact on the nation? Right? So I think, yes, that is the answer, but it needs to be implemented in two things: education and legal implementation.
Thank you very much. I appreciate it. I also agree with everything what you say. The so-called normality will become abnormal in future. I and you will be abnormal. And I know the meteoric rise and probably the most plausible meteoric fall also, and the fall of Rajneesh. It is better to have spirit rather than spirituality. Those who go behind spirituality will end up with it. Better have spirit Zargar tonight rather than spirituality. Now, coming back to education, we have got Dr. Pramila Kalra, who likes lifestyle modification. And all of us know lifestyle modification is the foundation, cornerstone of obesity management and diabetes. Without the lifestyle management, there is nothing like medication. Dr. Pramila Kalra, Zargar all said, what do you think lifestyle modification important? Two important things. One is diet, another is exercise. Everybody has education. Does that knowledge translate into action is the problem? What do you suggest?
Yeah, you're rightly pointed out, sir. Good evening, everyone. So as the discussion is going on, even if you see the data which has come up or the studies which have been done in India, even if you see the INDIAB study and the other data about the physical activity, they have clearly shown that 50%, approximately 54% people are inactive. And only out of that, even the females are more inactive. And if you compare the females and males, the males are a little bit more active. But even then, it is like nearing 50%, if you can say, or 47% males were inactive. And if you see the highly active, they were hardly 11% to 12%. So that is the amount of the physical activity which is seen. And if you see the physical activity which is recommended for weight loss, that amounts to around 400 minutes of physical activity minimum in a week, which absolutely is not followed by most of the people. They may follow it for some time, they may do it, but they are not regular with that. And if you see, finally, we end up telling the patients, okay, at least do 150 minutes. Now, it's not harmful. It's not that if they cannot do 400 minutes, the 150 minute is going to be harmful. Yes, the 150 minute will not help in weight loss, but at least it will give the cardiovascular benefit. It will give the other benefits of the exercise. So that way, mental health benefit, those things will be remaining. But if you are talking about physical activity needed for weight loss, it amounts to around 400 minutes minimum. And along with that, we have to have different sets of exercises, including the aerobic exercises, the resistance also, which most of the people don't do. So that is another thing. So what we normally tell our patients, that at least if they are sitting continuously, every half an hour, at least if they get up and they walk around for 5 to 10 minutes or stand and then sit, at least that much they can do. Because when we talk about physical activity or we tell them about physical activity, it is very difficult for many of the patients to comply with. So at least something which they can do in their workplaces, getting up every half an hour, not sitting for prolonged periods, doing some of the work standing. This is what we counsel them, at least, which can help them to at least maintain the cardiovascular health and the mental health. But for the weight loss, we need much more.
Thank you very much. We have few questions. I think we should answer them before we close this. This is a very important question, Dr. Pramila. Does intermittent fasting help in reducing weight? Both patients and doctor ask you, what is the scientific basis? Do you agree intermittent fasting or low calorie diet?
There are different studies. If you talk about intermittent fasting and low calorie, now this is a very, very controversial, debatable thing. If you see, many meta-analyses have clearly shown that calorie restriction is the major thing. Like even if you talk about intermittent fasting, yes, the intermittent fasting or the time restricted eating, where people decide the particular time for eating and the rest of the time they don't eat. And even in the time restricted, they have tried to see morning eating or evening versus evening eating. So all these have been studied. Yes, it does help in weight loss. But finally, if you see the meta-analysis as a gist of all the trials which have been done with intermittent fasting or time-restricted eating, the calorie restriction is the main thing. That is one thing which has to be practiced, because we have patients who have done intermittent fasting, but they haven't followed the calorie restriction. And then we don't see that amount of weight loss, which we see if the calorie restriction is done. And it is also very important, if we talk about our Indian setup, the calorie restriction alone may not be the only thing. It is also the type of the diet they take. If you see, the Indian diet is quite poor in protein also. So what we have seen, that our patients consume a huge amount of refined carbs. So if we replace some of this carb with the protein and add more fiber to the diet, even if they don't change the type of carb, it actually helps in weight loss. So we cannot be very stringent with the terminology intermittent fasting only or time restricted eating or the morning eating and the evening eating. But even if the patient is following a calorie restriction and taking the adequate amount of fiber with good amount of protein, and maybe little bit shifting from refined carbs to complex carbs, actually it actually helps. So practically, if we talk about, this is what actually helps the patient, because most of the times they don't follow this intermittent fasting for long periods. They follow it for 6 months, 1 year, and then they give up. So that is why the studies have finally shown calorie restriction to be the best.
Actually, there was a paper, small number of RCT from Korea. I'm sure you have seen. Though it's not more than 60 patients, it showed at the end of 6 months, there is no difference between intermittent fasting and low calorie diet. You like
Yes.
intermittent fasting, you do it. Somebody else likes a low calorie diet, small breakfast, small lunch, small dinner, equally it is good. This is a
Yes.
question for you, because it's not fair if we don't, because we said good fat and bad fat. Fat anywhere is bad. Brown fat has a very important role in burning calories and reducing body weight. How to utilize this brown fat? How to increase this brown fat? Is there anything lifestyle modification or medication? What do you suggest?
So yes, if the person has to, if we talk about the brown fat, we know that this is a good fat that helps to not only break down our, like, control our blood glucose, and it creates heat. But we know that brown fat, to increase the brown fat, we know that we cannot just increase it. We cannot just say that we'll increase the brown fat. But as with aging, we know that the brown fat comes down. So what happens that if patient does regular exercise, if they try to maintain their routine, they can actually maintain the good fat. That is what we can say. But we cannot increase the amount of brown fat. But yes, with aging, we know it comes down. But if the people try to do weight loss, they can, we know that irisin is connected. Even metformin has been shown to have some effect on the brown fat, on the irisin level. So if the patients maintain the weight, if they follow regular lifestyle modification, I think that is what can help to increase the amount of brown fat in the, like, maintain the brown fat and help to maintain the calorie loss, the weight loss.
Thank you very much, Dr. Pramila Kalra. I would like to thank all the speakers, Dr. Abdul Hamid Zargar and Dr. Rageshwar Reddy, Dr. Anup Mishra and Dr. Pramila Kalra being panelists. And I would like to thank all the audience for an excellent interactive session. There are many more questions. Unfortunately, we cannot take because I have already exceeded 5 minutes. So I thank the organizers, especially Dr. Sangram as well as Vishwanath, for giving me an opportunity. I would like to hand over the mic to Dr. Vishwanath for his closing remarks.
Good evening, sir. Thank you very much, sir. As usual, your crisp and informative session, moderating this entire event. And of course, as you rightly started, one of the most important aspects, and you have been able to moderate. First of all, I thank Dr. Zargar, sir, for that excellent talk in the beginning, explaining about the epidemiology and how it's becoming a pandemic, or it's already a pandemic. I also thank Dr. Nageshwar Reddy, sir, as usual, with explaining the newer novel procedures. And probably, as Prasanna sir said, probably this is the future. And we have to know when to refer such patients to them. I also thank Dr. panelists, Dr. Anup Mishra, Dr. Singhal, and Dr. Pramila Kalra, madam. Madam was in Dubai. I don't know. I think she's back. Anyway, thank you very much for being a part of this. Always we thank Dr. Biradar, sir. He arranges some of the excellent webinars based on these days, Obesity Day or so. And I thank all the delegates, all the participants. Biradar, sir, I think if he's there, he can conclude. Thank you.
Yeah. Thank you. I thank all of you, sir. Thank you, Dr. Jargar, sir, for accepting our invitation in short notice. And thank Dr. Prasanna Kumar, sir, for their excellent moderation, and all the faculties. Dr. Nageshwar Reddy, in his busy schedule, he took up the time. Dr. Anup Mishra also, he had back-to-back programs, 3 programs running, and Dr. Pramila Karla, and all the audience who have joined. Of course, we could not answer a few of the questions. We will answer the questions in direct one-to-one on basis if required. Thank you, one and all. Once again, thank you.
Mail the questions, yes.
Yeah.
Good night.
Thank you, sir. Thank you, sir. Good night.
Good night, everyone.
Good night.